Thank you for the presentation. Very happy to be part of the BANTAO Congress and to present some of the clinical associations that we found with different patterns of intradialytic hypotension. So intradialytic hypotension is one of the most common complications that we come across with during our HD sessions, with quite a high prevalence and with significant clinical associations with myocardial stunning, cerebral mesenteric ischemia, arteriovenous fistula thrombosis, and overall higher mortality and morbidity. However, what I want to highlight is the fact that there is no current consensus on the IDH definition, with 5 acting definitions in the literature, which makes the studies quite heterogeneous. The incriminated risk factors for IDH are high intradialytic weight gain, the presence of diabetes, ischemic heart disease, older age, female sex, and a higher BMI. However, when IDH occurs, so the timing of it has not been extensively studied until now, and this is exactly what we aimed to see, whether the occurrence of IDH patterns are associated with different clinical and dialysis-related factors. So we conducted a prospective observational single-center study on 131 patients, and we recorded 1,572 dialysis sessions. We measured blood pressures pre-dialysis and then every hour, and we used the KDOQI definition for IDH. In the same month of assessment, we also recorded demographic factors, comorbidities, SGA scale, biochemical and hematological factors, dialysis prescription, residual diuresis, and vascular access particularities. So we stratified our patients on early and late intradialytic hypotensors based on the frequency of their IDH events, and we noticed that there is an early IDH pattern in almost 30% of our patients. And when we further processed the statistics, we saw that the early IDH pattern patients have higher ferritin levels and higher SGA levels, while the late ones had lower residual diuresis and a higher UF rate. So I would like to highlight that different patterns of IDH onset may characterize different clinical associations and subpopulations of patients. And an interesting hypothesis that should be verified in obviously larger studies is that early onset IDH might have inflammation and malnutrition as a possible underlying mechanism, while the late onset IDH patients have the typical hemodynamic mechanism. Even though this topic has not been very extensively studied, I would like to mention this paper that was published in Kidney International on quite a large cohort of patients written by an American group, and they saw that patients who develop hypotension in the first 30 minutes of their dialysis sessions have a much higher cardiovascular mortality than the rest. In conclusions, not all IDH patterns are created equal, and recognizing different associations might help us better tailor our prescription and IDH management. Thank you.